Hello, this is Jenny, the colorectal intern. I'm incredibly sorry for the late consult. My knuckles were white as I gripped the open medication chart and progress notes, which were held on standby, ready for a barrage of closed questions from the aged care registrar on the other end of the phone line. It was 3:45 p.m. on a Friday, and I expected to be berated for asking for this untimely consult for consideration of inpatient rehabilitation for my patient, which probably could have waited until Monday. I was shocked, instead, to hear words of praise on the other end. What a fabulously concise, yet detailed consult. Thank you for outlining all their allied health reviews and rehab goals. Sounds like he needs inpatient rehab. I'll bring the aged care boss around this evening. 4 years on, and maybe even a decade or more on, I can say that unexpectedly positive response from the registrar has left a lasting impression on me. Welcome to another special guest episode of Oncology for the Inquisitive Mind with your hosts, Dr. Josh Hurwitz and Dr. Michael Fernando. How are you today, Michael?
I'm very good, Josh, and I'm so looking forward to our guest today and all of the pearls of wisdom she might have.
That's it. So today we have the honor and privilege of interviewing Dr. Jenny Liu, an early drug development / phase 1 trialist and medical oncologist at the Kinghorn Cancer Center. Thanks so much for being on the show today, Jenny.
Thank you, Josh and Mikey. And oh my gosh, where did you find that horrible piece of writing?
I mean, I think it was pretty good. There were a couple of grammatical things we could talk about.
But this isn't a literary podcast.
Yes, and you can see why I chose to be a doctor and not an author.
No, it was great. So for those who didn't realize that, it was written by none other than our interviewee today. Jenny, before we get into the nitty-gritty of our podcast, I have a little bit of an introduction about yourself just for our listeners, if you bear with me for a couple of minutes. So Jenny, I think Michael and I would agree in saying this, she is a rising star amongst early career oncologists. Jenny has or had already achieved more than most of us before pursuing a career in oncology. Having completed a PhD during her medical school training, she was awarded the University Medal in Medicine, which is the most distinguished academic award bestowed to an undergraduate at the University of New South Wales. That is a top 50 university, I think, globally. Jenny completed her PhD in 2011, and this was on colorectal cancer epigenetics. And during the rest of her training, she's managed to maintain an active research role along with getting her letters and specialization. Concurrently, she's also an honorary researcher at the Garvan Institute and visiting scientist at the Children Medical Oncology ProCan Group, where she liaises with collaborators nationally and internationally to utilize novel high-throughput mass spectrometry pipeline with accurately measures tumor tissue proteomes to identify signatures associated with treatment response and outcomes in multiple cancer cohorts. But on top of that, Jenny has an active phase 1 trial development schedule, works full-time at the Kinghorn Cancer Center, and manages to publish a significant amount of research. So thank you so much for joining us today.
Thank you, Josh. I'm incredibly embarrassed and flattered by your introduction, but it's lovely to be here and talking to you both.
And a novelist as well.
Most definitely. Jenny, I wanted to start by talking about your PhD and specifically, I guess, what your chosen topic was, what it was like doing a PhD in and around sort of university before you had gotten onto the medical rat race, as it were, and how that has informed not just your medical knowledge and practice going into oncology, but also how it's informed your subsequent career as a very prestigious researcher.
Yeah, so I guess, Mikey, my route in training is quite atypical in that many people tend to do, especially in oncology, a PhD towards the end of their training. I really got an opportunity to do research with quite an esteemed clinician, scientist, Professor Robin Ward, who now heads Sydney University, Faculty of Medicine and Science. So back then, she was a quite avid oncologist and researcher. And during my honours year in medical undergraduate school at UNSW, met her and got to understand some of the research she was doing in bowel cancer being such a prevalent cancer with very high unmet need. One of the things at the time I was interested in looking at was environmental factors that increase risk of some bowel cancers that had aberrant DNA methylation profiles. And through the honours project, I got to explore methyl donors, folic acid, and the influence of dietary factors as well as alcohol on the development of these cancers. It took me a long time, though, to establish one of the assays to measure folate using mass spectrometry. And because I couldn't really see the fruits of the labour of my honours through just the 1 year, I made the quite difficult decision to defer my undergraduate training to continue that research in a PhD. On one end, I think that was quite sort of challenging, seeing all my friends graduate and start working ahead of me whilst I was sort of slaving away at the lab and doing 70-hour sort of weeks, dissecting mice guts and all sorts of fun things, growing organoids. But I think the PhD really taught me lots of skills in terms of research, in terms of synthesis of data, collaborating with scientists and other clinicians, setting up a tumour biobank, and growing these mini guts, which I like to call sort of organoids. And all of that really came together in a nice body of work where I was able to set up a new method for measuring folate species in bowel tissue and identify some new relationships between how folate was processed in the gut and how this could lead to abnormal methylation and a subset of bowel cancers. It's quite exciting. Over 10 years from the PhD, one of the LGR5, which is the target identified back when I was doing my PhD as a stem cell marker in bowel cancer, has actually now been translated into a CAR T product. And in fact, recently at St Vincent's Hospital, we've been selected as a lead site to actually run this CAR T trial. So it's actually brought my research over a decade sort of back into relevance again in terms of my role as a phase 1 oncologist. So would never have predicted that as a medical student. But I think certainly doing a PhD is not sort of for the faint-hearted. And one of the key things I always tell my colleagues and my peers considering a PhD is to always pick the right lab, right project, and pick something you're really passionate about, and sort of the rest will work out.
Jenny, one of the challenges we always have on this podcast is the last 2.5 minutes of you talking, I have about 40 plus questions. And I know we have to sort of move on to kind of get a big picture. But there is one, I'm going to go on a tangent here. Can you tell our audience a little bit about CAR T therapy and also, I guess, why we don't see it very much in solid organ cancers?
Yeah, so certainly CAR T is a very big area in hematological malignancy. And I think we are at St Vincent's Hospital very fortunate to work alongside some established hematologists who have been working in CAR T space with various hematological malignancies for quite a while. And we've got several active CAR T trials that are recruiting at the moment. So I think many of the listeners will be familiar with the basic principles of CAR T or chimeric antigen receptor, also known as chimeric immunoreceptor therapies. And these are basically cellular therapies and receptor proteins that have been engineered to give T cells the ability to target a specific antigen. And so the ideal target for CAR T is an antigen that is present on tumours that is not present anywhere else in normal tissue. And one of the challenges in solid organ malignancies is that unfortunately solid organ tumours are very heterogeneous and they undergo clonal evolution as the cancer starts from a single tumour into multiple metastases. And so finding this single antigen target is really challenging. one of the things with solid tumors is just getting the CAR T into the tumor can be very hard because of the very immunosuppressive tumor microenvironment. So to date, I don't think there's been that much widespread success in terms of CAR T therapy. There's been a few very exciting case studies, including an N=1 study published in the New England Journal last year in pancreatic cancer. I'm not sure if this new trial that we're going to run will be able to emulate that success, but certainly I think there's a lot of ongoing research and work into this space.
You can really see the thorough and very deep understanding of just the basic concepts of going into of large research projects, Jenny, just in the way you describe something as complex as CAR T. But there was one part, to drag Josh off his tangent, there was one thing in his introduction that I wanted you to talk a bit more about, because I must confess I'm not too familiar with it, and that's your ProCan program. Would you be able to tell us a bit more about this before we get into the nitty-gritty of phase 1 studies as a concept, I guess?
Yeah, sure. So I guess this probably comes back down to the challenge that we have in terms of identifying biomarkers of treatment response, and also prognostic biomarkers to understand, which patients with good prognosis, head and neck cancers that I treat in my day-to-day practice, won't have recurrent disease and potentially could benefit from a de-escalated therapy, in which patients, even those with the good prognosis HPV positive head and neck cancers, have aggressive biology that might need more intensive treatment and surveillance. At the moment, we are quoting patients sort of probabilities of their cancer coming back, but there is really increasing interest of doing multi-omic analyses of tumours to understand better biomarkers to predict treatment response and resistance. So the ProCan team is a large academic team headed by Professor Roger Riddell and also Phil Robinson. So Roger is a scientist, but actually did train as a medical oncologist many decades ago. Phil Robinson is a proteomic scientist, and several years ago they had the very ambitious idea to set up a very high throughput facility where they have multiple mass spectrometry machines, and to churn through hundreds of thousands of tumour samples of all different tumour types, stages, and to answer the question of whether we can use high throughput proteomics to identify these biomarkers. So that team has grown to about 40 or so scientists now, and includes proteomic scientists, data scientists, but increasingly also medical oncologists. How I came to be involved is at the end of my clinical training, I still needed to do 6 months of training to complete my time for my letters, thanks to 6 months of maternity leave that I had as advanced trainee. And I got to know Roger Riddell and found that the work they were doing was very interesting. So I actually took up a research fellow position with them to help with bringing clinically relevant questions and cohorts into the ProCan team. So yes, it's growing, and we've now got several PhD students who are also medical oncologists working in that space.
Wow, what a exciting time, I think, to be in the oncology or research sphere. Moving on to, I think, maybe a little bit more applicable to our junior colleagues looking for future career directions. Jenny has done remarkable things, as you can probably already hear. But before I came to the Kinghorn and started working with such a supportive team, I didn't know very much about early phase trials. We'd had some phase 3 studies. They were all kind of a bit, not esoteric, but I felt detached even as a junior registrar. Can you take us through maybe even your decision to become a clinical trialist or early career drug development specialist, and maybe just talk us through your thought process, what you love about it, and what you can gain as an oncologist looking to, set yourself apart from the hordes?
Yeah, so I think the early phase opportunity for me actually came about fairly unexpectedly. So I had done all my core training through Chris O'Brien Lifehouse, RPA, Concord, which is a fabulous network. But also, like you, I, through my core training, did not have much experience with early phase trials and drug development. And so I did want to broaden my experience a little bit and also in a different network. So worked at Westmead and Blacktown Hospital, which also has a very good trials network, and worked as a trials fellow. And particularly at Blacktown Hospital, got a lot of experience working in early phase trials and really enjoyed that role. I guess broadly, early phase trials refers to phase 1/phase 2 clinical trials that focus more on exploring novel compounds or novel compounds in combination in patients for the first time, identifying toxicity and the right dose, and then exploring preliminary signs of efficacy, usually in expansion cohorts. Once there's promising data in that space, then trials then often move into a more phase 3 setting where there's often randomization with a standard of care regimen. Something I really enjoy in early phase trials is the ability to interact closely with scientists and sponsors. So we do have lots of meetings to discuss data as patients are enrolled, and the safety of each dose level is evaluated. But I think in doing that, we're able to really engage deeply with the researchers who are coordinating and running the trial, as well as other investigators from all around the world. So I find that aspect quite enjoyable. Increasingly, I think Australia is a really attractive place to run early phase trials, the way our government and tax incentives and our efficient startup timelines are compared to other countries overseas. So we are seeing increasingly more and more early phase activity across many hospitals. Even in New South Wales, we have a really robust network of 10 hospitals that run trials, and we coordinate and collaborate together. And I think really this is going to see an increasing opportunities for our patients to access novel therapies, especially in rare cancers where there may not be good access or good funding for effective treatments for these cancers. So I think really benefits patients. From a clinician point of view, having experience in drug development, I think is really helpful in being, employable and potentially looking into translational research as well, because you understand how to bring a drug from the lab into the clinic.
And Jenny, sort of just to ping off what you mentioned just then in terms of benefits of early drug development and working in that area, I know that there will be at least a handful of people listening to this who say, this sounds great, Jenny, you've sold me. From your end as someone who's looking to bring people into the early drug development fold, are there any sort of particular skills or attributes that you think would set a theoretical, hypothetical candidate, as an example, in the early drug development phase?
Yeah, I think probably the attributes that are most important working in clinical trials is attention to detail, because certainly trial protocols can be very complicated. Eligibility requires very thorough checking and cross-checking, and patients' eligibility for specific trials changes, and sometimes even protocols can change as well. So I think having that attention is quite important to ensure that data is captured accurately, but also that we're efficiently assessing our patients and matching them for the right trials, because patients who come to see us for trials often have advanced disease, which is often treatment refractory, and they don't have the luxury of time. So we really want to get these patients onto treatment if there is a good option for them. Other attributes, I guess, is being a very strong team player, and certainly we're very lucky here at the Kinghorn to have a fabulous team of almost 10 phase 1 coordinators. We work closely with our regulatory team, with trials pharmacy, and also education and startup teams. And in phase 1, one of the really great things is that we're not working in isolation, and there's often many investigators and many coordinators who step in and help each other out. So being able to collaborate and work closely with study coordinators is, I think, really important.
It's always nice to feel that you're not a silo in a big system of cogs. So that's good to hear, Jenny. Since your time doing, I guess, phase one, and from a person on the ground running numerous trials, what do you think, if we're futuristically looking at the trials you've got now, and let's talk about, you've got osimertinib, which, 5 years ago was unheard of, all these amazing drugs. What do you think is the most underrated novel agent that you've seen to date, or they might have the biggest future application?
I think that's a very tricky question, because certainly there's so many drugs and opportunities.
I
I
won't
think
hold it against you, Jenny.
I'm actually not going to name a specific drug, but I think what I'll say, and this probably comes back to my work with ProCan, is I think we need to be looking actually more at novel combinations. So taking osimertinib as an example, it works really well in the vast majority of patients with EGFR mutant non-small cell lung cancer, but there are some patients that don't derive good benefit. And in some earlier research I did with one of my predecessors and mentor, Stephen Cow, we identified that PD-L1 high EGFR mutant non-small cell lung cancer patients tended to not derive as much benefit with osimertinib. And so the question was, could we add a combination to osimertinib to improve their response? And I think there are many examples across all tumor types where like a single drug, KRAS G12C alone may not work well in some patients. You really need to look at a combination. There are many trials in this space looking at combinations. And so I think we do need better biomarkers to be able to mine our existing drugs better.
And Jenny, you've mentioned before, obviously, that these the patients that enter into early drug development trials, phase one trials, I think most people who have worked in oncology, leaving aside the actual physical trial component, would have seen people on early drug trials. And as you've said, they're usually very heavily pre-treated. They can be really feeling the effects of their cancer and after effects of previous treatment. But what, in your experience, are some barriers to these patients actually being involved and getting involved in phase one trials? Because it is a significant investment in time, effort, and it can be quite taxing.
Yes, absolutely. So I think phase one trials are not for everyone, and certainly it takes the right patient with the right sort of biology, potentially a right biomarker, where an early phase drug might have a much higher chance of efficacy. But also there are other complicated factors, including patients' background, their socioeconomic and their cultural background and English speaking skills, which can make enrollment to trials more challenging. My colleague, Dr. Abhijit Powell, is really making progress in this space with his PhD, looking at improving access to trials by the cold population. And I think we have a long way to go in terms of making trials more comprehensible for people who don't speak English well and who are not very literate. If you look at a typical patient information consent form, they're often 20 pages or longer with very technical jargon, and there really is a need to be able to simplify what trials are and simplify patient information sheets for people of all diverse backgrounds. Geography has also been challenging, but I think with COVID-19, there's been some really great improvements in trials access for patients who are based in regional and remote areas in Australia. Throughout COVID and looking at our own data, about a third of our patients treated at the Kinghorn Cancer Centre in the last 2 years came from regional and rural areas across Australia. And in fact, we actually didn't see a decline in where patients came after COVID lockdowns. And we think this is probably due to increased telehealth, the ability to do remote monitoring, sometimes able to liaise with local hospitals to do things like disconnection of 5FU and other local assessments in between PK dosing for people closer to home. So I think there's still lots of barriers with trial participation, but hopefully over time we'll be able to gradually overcome some of those challenges.
My next question was going to be how can one achieve to overcome such barriers, but I feel that's a bit of an open-ended question and maybe not a huge. There would be ongoing challenges to actually answering that, given how things are developing. What I would love to talk about is this elusive name called Nectar. Nectar being a potential, I guess it's heterogeneous group of hospitals that work together to share trial information, data, liaising with medical oncologists. The whole idea that if there's not a trial available at one site, there might be another trial available at another site that fits, KRAS G12C, mutation or something like that. Could you talk us through, and I don't know if you're involved in the development of it, but how that's come to be and the benefits for patients and clinicians in utilizing such a broad network of information and opportunities?
Yeah, it's a great point, Josh. And Nectar actually came about before I started. It stands for the New South Wales Early Phase Clinical Trials Alliance. And I believe it started up maybe about 4 or 5 years ago when a few phase one centres in New South Wales, namely Lifehouse, Scientia, and St Vincent's Hospital, identified the need to be able to collaborate in terms of being able to bring patients to trials that might be in a specific location, to be able to cross-refer potential trials that one site couldn't run, but another site might be able to run, and really help with moving drug development forward in New South Wales. These days, we're very fortunate to have a dedicated manager, Nectar Max, who really does a lot of work on the ground with coordinating a lot of us and hosting the fortnightly meetings that we have. The network comprises about 10 hospitals around New South Wales, and we together review cases if there's a challenging patient needing a phase one trial option. We sometimes look at trial feasibilities together to identify the most suitable sites and then to ensure that we're not overlapping in terms of recruiting a competing population. And each year we also host an annual drug development meeting. The most recent one was only a few weeks ago, where we're able to bring a few key speakers internationally, as well as identify some exciting pipelines from some major biotech and pharmaceutical companies. So yes, I think it's a really great network, and I think it's a really strength in numbers.
Jenny, if I might sort of pick your brain about your own personal experience, because as you've mentioned, in any early drug development team, the emphasis is very much on team. But in terms of your own personal experience in this area, my question is twofold, really. What would you say is the most rewarding aspect of your job? And you can choose any sort of aspect, the interpersonal, the professional, the scientific. And the flip side of that coin is, what do you think is the biggest challenge that you've experienced in the area?
So I think in terms of the reward, the interpersonal aspect, I think really comes down to the core reason I chose oncology is being able to work really closely with patients during a very vulnerable, challenging time in their life and making a difference to their journey through cancer. And I think phase one trials is really at the pointy end of that, when often patients might be struggling supportive care versus trials, or perhaps considering a standard of care therapy which may or may not have very good efficacy. And helping patients and their families come to that decision, I think, is sometimes a very challenging one, and often requires sort of understanding a lot about the patient, what their values are, and whether or not a trial is the right thing for them. I don't refer all my patients onto a trial, and in fact, sometimes I might refer them for a second opinion if they're really actually seeking to understand if there's any further standard care therapies that might be appropriate. And in many, I do involve palliative and supportive care. Sometimes the trials don't work out, and the patients, progress after the first scan or even before the first scan. But I think sometimes the closeness with which we work with our phase one patients, the fact that we see them so often, and that interpersonal relationships sometimes can be as therapeutic, I guess, as the drug itself in a way. So, I mean, of course, we'd hope that the patients that we treat respond, derive benefit, live longer. But I think quality of life is also really important. And one aspect which I'm not doing much work on, but I think we do need to look on more is PROs and quality of life for patients on early phase trials. In terms of, I guess, challenges, so I think paperwork's probably one of the biggest challenges, the amount of signing, the amount of meetings, and the fact that sometimes these are outside of working hours, which can make work-life balance somewhat difficult, especially with a young toddler in the house. So, yep, that's probably something that's the hardest in the role.
Work-life balance is something that I think you probably still do a remarkably well, given everything you're juggling at the moment, Jenny. And the comment that struck me that I really resonate with is helping patients and their families understand, I guess, trials and their disease. And it's about holding their hand, not holding their hand, but assisting them through their journey with cancer. Because most of these drugs, despite our best efforts, won't cure someone, but at least they might give them some good quality of life and some time with those they love. And you can't help but get involved and care about these people who just want to, live another year. Taking a slightly different track now and looking at some of your other work, Jenny, Michael and I have spoken on this podcast many a time about online and offline, about where do we want to see our careers going and what do we want from our career in oncology or medicine or treating cancer. And you've done something remarkable which hasn't been done in Australia and maybe only limited internationally. You've created essentially a transgenerational mentorship program where senior oncologists are linked with junior registrars or even senior registrars to kind of help with career building and development and exploration of what their wants and their needs are. Can you talk us a little bit more about how this came to be and what your aims are with this?
Yeah, I guess the first thing I wanted to highlight with the mentorship program is again that it's a team effort, and you really need to give kudos to Dr. Udit Nindra, who's been on the ground driving the mentorship program. So he's currently a training and PhD student at Liverpool Hospital. Josh, you know him very well, having recently co-authored with him. But Udit and I have been doing this initiative now for a bit over a year, and it sort of started with my role with the New South Wales Medical Oncology AT Committee, Advanced Training Committee, where we were developing educational resources and opportunities for trainees across New South Wales that identified that there actually was a lack of avenues to help trainees with career guidance and to help with increasing their professional fulfillment. And so identified that, mentorship really could fulfill that gap. There's been some work in other specialties. So one of my previous mentors, Bethan Richards, who's the Chief Wellness Officer at Royal Prince Alfred Hospital, set up a mentorship program for basic physician trainees there. And we used some of her surveys to survey the oncology workforce. And last year, in a pilot mentorship program, identified these phenomenal rates of burnout. 93% of trainees and 54% of consultants were classified as burnt out on the NASDAQ Burnout Index. And in that small pilot, we really got great engagement, and a lot of the mentors and mentees felt that by matching and being able to have an independent person to debrief with really sort of helped them throughout the year, which was really hard with COVID. And so with that success, this year we've rolled out the NOMP, which stands for the National Oncology Mentorship Program, which we're very fortunate to have formal MOGA sponsorship. That's been rolled out last month, and we've had already 56 pairs sign up nationally. The data, I won't be able to share all the data as yet, but it's quite alarming, the rates of baseline burnout as well as low professional fulfillment. And I think, as both of you have identified, career uncertainty is a major driving factor for that in trainees. So that's hopefully something that we'll be able to help with moving forwards.
It's a fantastic initiative, and for our Australian listeners, if you're feeling a little bit under the pump, as we all do, or even if you're not, it's definitely something that we would encourage you to explore and sign up with. And I guess, Jenny, with that program, if I may encourage you to dream, as it were, in the years going forward, what do you envisage for the mentorship program? Do you think that there might be other avenues of education or support? Paint me a picture, I guess, of where you might think that this fantastic initiative may end up.
Yeah, so at the moment, the 2023 program is entirely virtual. So our initial kickoff meetings were done on Zoom. We do hope to have a face-to-face meetup at the MOGA annual scientific meeting in Perth this year, but hopefully with funding and more support next year, there will be more face-to-face components so that mentors and mentees can meet up in person. And we've tried to match most within the state to make that logistically a bit easier. I think moving forward, having a regular process by which trainees who enter oncology have a system where they can sign up with and meet a mentor who can help them throughout their training would be fabulous. And I think there's also a role for people like myself who are sort of earlier phase junior consultants seeking mentorship from more senior established consultants in particular areas that are of interest. Some of my colleagues have wanted to be matched with someone else who's been head of department, given their new role in that. Myself, I guess it would be great to find a mentor in the drug development space. So I think there's ongoing opportunities that mentorship can have in terms of helping trainees through, but also would help on the other end with succession planning as well, and identifying how more senior oncologists, if they want to cut down or change their pathway away from clinical medicine into other avenues, may be able to pass the baton on to their junior colleagues.
I think as registrars and fellows, we often forget that our specialists and consultant colleagues also have very similar questions, even if it seems like such a distant dream for people like Michael or myself. Jenny, we always finish our episode with one final thought-provoking question. You are someone who has blazed through so many challenges to get where you are today, and it's no feat where you've got to without so much hard work and blood, sweat, and tears. But if you could look back at a young Jenny, maybe even a intern Jenny or a med school Jenny, and maybe you've always had this dream and you're like, I'm going to be this phase 1 trialist and save the world one person at a time, what lesson or piece of advice might you give your younger self?
That's a great question, Josh. And I think certainly for me, and this might reflect similarly for others, over planning and trying to map your career out 5-10 years in advance into a specific niche area and subspecialty, I think may not necessarily work out that way. And a lot of us have anxiety because we're so familiar through medical school and then in training, knowing what the next year or two will look like. But when you get to the end of training, really the world is your oyster. You can really choose a role that fulfills your passion and your interests. And I think having being open-minded and enjoying the process is really important. When you get to the other end, there's actually heaps of other challenges and lots of other challenging aspects with the role as a consultant, bureaucracy, relationships, the responsibility, I guess. So enjoy time during training, because that doesn't come back. I think that's the key thing I would say to my younger self.
A typically wise piece of advice, Jenny. And thank you so much for coming on. It has been, as we always say on this episode when we have special guests, a tour de force. That's one of our favourite phrases to use, but it is no less true, of covering everything from science to perhaps opening the door a little bit and giving our listeners a peek into the inscrutable world of clinical trials, as well as giving a very human aspect to training. So it's really apparent. It's apparent to me. I know Josh has mentioned this at times, that you are someone who has a finger in every pie, talents in every area, and we really appreciate you spending a bit of time on our podcast and passing that on.
No problems. Thanks so much for having me.
Join us next time on Oncology for the Inquisitive Mind, where we will conclude our epic trilogy surrounding prostate cancer with a look at the later lines of therapy. This will include a look at lutetium, PSMA, a novel directed therapy specifically towards prostate cancer, as well as the more traditional chemotherapy with cabazitaxel. So we hope to see you there.
Bye.
Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.